you guys. We're moving on to the healthy prostate. Prostate cancer can devastate families, and it impacts Black men at a disproportionate rate. Joining us for a discussion on sexual health and prostate cancer awareness is American Board of Urology certified Dr. George A. Johnson. Dr. Johnson is dedicated to health education specific to men's health, with focus on prostate cancer and sexual dysfunction. He provides health education to the community through participation in health fairs, community meetings, and outreach, as well as to colleagues through continuing medical education lecturing. We are so very pleased to welcome Dr. George Johnson. Can you please give him a round of applause? You're welcome.
Good afternoon. How are you? Give me a moment and we will start to talk. If you give me a moment, we will start to talk. Is that better? Great. First, a correction. I think it was made clear that I'm actively practicing. I'm currently a partner in a large health conglomerate called Summit Health. I practice in northern New Jersey, so I'm not Atlanta-based. But I think I know a couple of the urologists that are practicing here in the Atlanta area. One is Dr. Barnes, and I think I was fortunate to have known his father. And I think he came here, and after training and set up a practice, and I think he's one of your African-American urologist, I think, who's active. And I think he is my partner on the stage, his name is Dr. Scott Metcalf, is a primary care physician who's practiced primary care medicine in Atlanta for more than 20 years. I think he is, the CEO, or he is the director of an organization called the Chestang Integrative Medicine. So please say hello and welcome to my partner, who's going to be on the stage to answer questions and talk about prostate health. You want to say a word, Doctor?
Okay, yes. Thank you, everybody, for coming out. This has been a wonderful, wonderful panels that we've seen so far today. And like Dr. Johnson said, we're about to talk about prostate cancer and prostate health. And for us who all know Black men and have Black men in our family, husbands, sons, fathers, uncles, this is the lecture that we really want you guys to hear.
So let's start with, first of all, to those who may not know what a urologist does. A urology is a surgical subspecialty. I deal with the diseases of the urinary tract, kidneys, which is not shown in our anatomical diagram, bladder, prostate, and the external genitalia in the male. In the women, we deal with diseases of the kidney and the bladder. So, and again, as a surgical subspecialty, that means that we're involved in removal of structures, organs, treatment of tumors, cancers, treatment of stones, treatment of infections. So it is quite involved. And I think one of the areas that I have specialized in and I focused on for many years is diseases of the prostate. And we're going to start with a little anatomy. So if we look at this diagram here, this is an anatomical study of the pelvis in the male. And what it shows is the bladder, the prostate, the external genitalia, the penis, and the testicles. This structure here, this little tube here, is called the vas deferens. And when an individual, a male, is seeking to be rendered sterile, that structure is the one that's cut, and it prevents the movement of sperm from here to the point of ejaculation. Our focus today is diseases of the prostate. The prostate is a structure that's located below the bladder. It is by all definition, it is a portion of the urethra, and we call it the prostatic urethra. And it really serves as a conduit, a tube where urine, which is stored in the bladder, it's produced by the kidneys, which sit up here, collects in the bladder, and it's basically when a man urinates, the urine is passed through this channel down the penis to the outside. So some of the conditions that we encounter, men encounter, one of them is prostate cancer, which we're going to talk a little bit about, prostatitis, which is an infection of the prostate, and benign prostatic hyperplasia or benign prostatic hypertrophy. We're going to start with a discussion about benign prostatic hypertrophy. Now, the prostate is subject to changes as a man ages. And one of these changes is enlargement. When the prostate starts to enlarge, it starts to impinge and push up on the bladder. So this structure, which is supposedly starts out as the size of, say, a walnut, but it can be much bigger. It can grow to the size of an orange or even a grapefruit. When that happens, it starts to obstruct the flow of urine from here and requires intervention from a urologist. What are the symptoms of BPH, as benign prostatic hypertrophy? Men have difficulty starting their urinary flow. They may go frequently. They have what we call hesitancy. There can be the sensation that they're not emptying or sensation of incomplete emptying. Sometimes infections can recur. Bleeding can occur. BPH is a very common disorder that we start to see in men when they get typically into their 5th decade of life, in the 50s. It's rare in men in their 40s, but we can see it in some individuals. And by the 6th decade, men in their 60s, there may be 50% of men who may be bothered by some of these symptoms related to BPH. By the time a man reaches the 8th decade of life, about 90% of men are bothered by these symptoms. So it requires an evaluation. It's not that complicated to at least evaluate. We do studies that look and to measure the size of the prostate. We look to rule out infections. We check the PSA, which is a substance called the prostate-specific antigen. They do a rectal examination to evaluate the size of the gland. And we can also do a rectal ultrasound to more precisely evaluate the size of the prostate. I'm sorry, I thought. And then if we determine that there is a need for treatment, there are a number of things that can be done to treat BPH. One of them is medical management with medications we call alpha blockers, which can help to relax the muscle. So muscles in the prostate, again, they can be relaxed by these medications called alpha blockers, and it allows for the easier passage of urine. And on occasion, it requires a much more aggressive intervention or surgical intervention. And these surgeries involve scraping or removal of prostate tissue. The next condition I'm going to briefly talk about is prostatitis, which is an infection or inflammatory condition of the prostate. The symptoms that one may experience with prostatitis is very similar to the symptoms that one sees when there's enlargement of the prostate or BPH. But many times these are very acute in onset. They come on very suddenly. There can be burning, there can be fever, blood, pain, and this typically suggests an acute infection which requires the use of antibiotics. Prostatitis can sometimes take the form of a more chronic condition, and it can continue and it can recur, it can smolder, meaning that you will treat it, it'll get better for a short time, and then it will recur after a period of time, requiring additional amounts of antibiotics. And And on many occasions, you may have to even go further and do procedures that involves looking in the bladder, looking at the prostate to examine it to make sure nothing more significant or more serious is present. The third item on that list was prostate cancer. And I'm sure that obviously will arouse a lot of attention because it's a condition that affects the Black community all too often. And men of African American descent are more likely to be affected by prostate cancer than men of other ethnic groups. If you have a brother or a father who has prostate cancer, the incidence of prostate cancer can be doubled. So therefore, the family history is critical when considering or thinking about undergoing screening for prostate cancer. There were approximately 270,000 new cases of prostate cancer in 2022, with about 34,000 deaths. It's significant. A majority of the cancers, though, that occur are what we call low-risk disease, which can be managed, treated, observed, and men are not required to undergo significant treatment such as radiation and surgery. But there are a percentage of these diseases that are very, very aggressive and can end up in the death of its host. So it's important to understand the need for screening, the need to be managed, monitored, and checked if there's a concern for prostate cancer. A quick comment about prostate. This is not that important for our discussion, but most of these cancers we call adenocarcinomas, and that's just a technical point that. Now, these are some of the warning signs which we talked about, okay? The pain, these are important because if you're experiencing these symptoms, you need to consult with your doctor, and you may want to reach out to Dr. Metcalf as your primary care doctor, who can then decide if you need to be seen by me, the urologist. But it's important that you establish a good relationship with a good primary care physician. And I call them as referred to Dr. Metcalf, as the quarterbacks in your healthcare team. And it's important that you have a good quarterback because they will coordinate your healthcare. If you need to have something done, basic blood work, that's the man or woman that can make it happen. And I think there's nothing more disconcerting than to go to emergency room in a hospital, not having a primary care physician, and be placed in the hands of somebody that you've never met in your life. Okay? So the importance of having and knowing that primary care physician who can serve as your advocate, who can be the source of a lot of information, all right? And who can take good care of you. I think we're going to have to open it up for questions. Doc?
Prostate, like he said, is about the size of an actual walnut. And with benign prostatic hypertrophy, when the prostate enlarges and starts blocking the urine flow, as he said, it can get as large as an orange. So imagine that in your pelvis and those symptoms that a male will present with. Now, being family practice, my primary goal is prevention, to prevent any illnesses, and do early detection, early screening. Black males, we start the age of prostate screening at 45.
If there's a family history of prostate cancer,
Yep.
the current recommendation of the AUA is that you start in your 40s
Yep.
with PSA and that examination we call the rectal examination that all you men love.
Yep. And the most important thing for me as a primary care physician, the incidence of prostate cancer that I have caught are very subtle. And I tell people that they have to know their numbers. We say that in a lot of things in medicine. So the average PSA is less than 4. Now, in primary care, just say if someone comes to me 1 year and their PSA level is 3, and we say, your PSA level is normal, but what was it last year? Because if last year your PSA was 2.3, that's abnormal. So anytime your PSA increases over 0.7 in 1 year, even if it's in the normal range, if it goes from 1 to 2, something abnormal is going on, and I'm gonna send you to Dr. Johnson.
Absolutely, and that's referred to as velocity, and that's the change in the rate of rise. And so if you see an increase in the velocity or the rise of PSA, that's something that requires a very close look, observation, repeating the PSA to determine whether or not there's something you need to go further and maybe have a prostate biopsy.
Okay. And we have questions?
Yes.
Okay. Sir?
Please use the microphone.
I'm 59 years old. In reference to prostatitis, I had prostatitis when I was 33, all right? And the reason for that was because I had been celibate for a year. Now, are we sharing information to 30-year-olds, you know, in reference to that lack of sex? Because it does affect the system. I mean, it's a natural thing that you have to, you know, you have to have it. You have to release that pressure that's there because it builds up, especially in healthy individuals, as myself, as I was then, as I am now. But the other point I would like to make is that I was told by the physician, and in fact, I worked in the medical field for 15 years. I did cardiac catheterizations. And the urologist at the time I spoke with said, you would never get prostatitis again because you had it once. Now, when I had it, all right, now bear with me, they couldn't even figure, okay, I was in the hospital for 3 days before they decided to do a prostate exam because they had no idea. They couldn't figure out why in the world, or how could you possibly be having pain? And it took 3 days before they said, okay, we're going to have to check the prostate. They checked it. They said it was the size of a 56-year-old at that time. I was 33. And he said, well, you'll never get it again. And we used antibiotics, and I did the right thing. I wasn't celibate no more, that's for sure, you know. But that is one of the things that affect not only at the age of 33, but at the age of 50, 60, or whatever. It's important.
Okay.
Got it.
Prostatitis is a condition that is not necessarily that difficult to diagnose, okay? Look, the key to anything in medicine diagnosis, good history taking. You have to understand the complaints of the patient. You have to determine what sort of physical examination and physical testing you have to do, looking at urines, if you need to do imaging studies. But diagnosing prostatitis is not that challenging. You have to obviously rule out other conditions. Typically, it is associated with fever. You've got difficulty urinating, there's burning, sometimes there's blood in the urine, you're having pain. So if there's a septic episode, you've got elevation of your, excuse me, I'm getting technical. If there's signs that you have a whole body infection, in a male your age, and especially a young man, 30, that's one of the things that you think of first and foremost, okay, is prostatitis, acute prostatitis. Okay, so that made it more challenging, but you had pain. So it was probably an early presentation. But again, looking at the tests that one should evaluate, such as one's urine, and whether or not they need to do a CT scan, make sure your kidneys are fine, and so forth. But it is, most cases, not that challenging to make that diagnosis. And many times, when you are admitted or you go into an emergency room and you present with this pain or discomfort or urinary discomfort, many times they're going to start you on antibiotics and they're going to treat you as though you have infection. If they do a blood count and there's a suggestion that you have an infection in your body, that's how you're going to be managed. And that's usually, it's going to start the process of treating that infection, which they may obviously determine is an acute prostatitis. When it becomes recurrent, when you're having symptoms, say 6 weeks, 6 months down the road, or that those symptoms never really go away, then you start to define it more as a chronic condition, okay? Something that smolders. You don't really get rid of it totally. You treat it. Sometimes it's also selecting the appropriate drug, the appropriate antibiotic. Not every antibiotic will penetrate the prostate orally in the right amount of concentration. So you really have to be very selective about certain drugs so you make sure that you can effectively treat the infection, okay? So you're lucky. I'm glad you took the right corrective measures, and you're well.
We have another question right here.
Oh, okay.
Yes.
Yes, sir.
Somebody hijacked it. I'll go for it.
Okay, my question is, why is prostate, heart attacks, strokes, and high blood pressure is more common in black men than our common other parts?
The issue is genetics, okay?
Okay.
It has been determined that obviously, and cancer is, as we've come to understand, there's a strong genetic component that predisposes us to diseases, and sometimes more severe cancers. So the reason that men of color seem to have or get prostate cancer at a high incidence is because of genetics, genes. These are where we get it from our mothers and fathers, and it's passed on. And as I said, if your father has prostate cancer, if a brother has prostate cancer, the likelihood of you getting it is increased fourfold or maybe up to 8 times. And I've taken care of multiple generations. I've taken care of brothers, grandfathers, fathers, all of whom were diagnosed with prostate cancer. So yes.
All right.
I mean, they've had panels on those, but yes, a lot of genetics are predispose you to increased risk of cancers. We know that some studies say between 1 in 6 to 1 in 8 black males are going to get prostate cancer in their lifetime. And also the incidence, as Dr. Johnson said, of prostate cancer rises with age and environmental factors, with age and genetics. And then you also have, with a lot of cancers, you have environmental factors. We remember that alcohol intake increases your risk of nearly every cancer that's out there. Smoking cigarettes increases your risk of cancer, as opposed to the general population. The only thing with black males is that with our late detection, we're typically almost our prostate cancer is the second leading cause of cancer deaths in the United States for men. And we are almost twice as much our death rate over whites.
Tend to present much more later in the disease process. It's not diagnosed as early, and unfortunately, many times the diseases are much more aggressive because of genetics. And of course, we call it healthcare disparity. So.
Okay, we have 2 more questions right here.
Thank you so much. Thank you. And I feel like you kind of answered some of the questions, but I wanted to ask, so are there anything that we can be doing to prevent it? I know you spoke about genetics. You just spoke about some of the things, smoking, drinking, but is there anything I could be doing now in my 30s to prevent it? Eating, having more, sex, like he said, is that a real thing? Help me.
I offer to write prescriptions for my patients all the time for this, okay? So if you're interested, I'll write a prescription for you.
Okay.
But just not to joke about it, but I think one of the, and I'm going to let Dr. Metcalf, I'm sure he has something to say about this, but in general, look, prostate health, and I think the things that it can ensure prostate health is the same thing that can ensure cardiovascular health. Okay? It's really no different. We eat healthy. We avoid a lot of animal fats. We're talking about refined sugars. We're talking about trying to eat more complex carbohydrates. We discussed the fact that maintaining and managing our weight is critical. So those are the things that one can do early in life to avoid and try and minimize your risks of cancer, because these are all the things that we see higher incidence of cancers in patients who are suffering from obesity and patients who obviously adhere to a very unhealthy lifestyle. I call it lifestyle, but it includes diet, et cetera, et cetera. Exercise is important for one to maintain and to engage in for a lot of reasons.
One last question. I'm sorry, we're out of time. One last question.
Sir, you mentioned in your slide presentation that excessive urination is one of the signs. I drink quite a bit of water, so I don't know what's a normal amount of urination, or times that you urinate. What's normal?
Well, number one, I think the frequency of urination is definitely driven by what you consume. Okay, so if you're drinking a lot of water or other beverages, you're going to have to urinate much more frequently. Medications can also alter that. So depending on if you're on a diuretic, water pill, or certain other medications which can make you urinate. I think it's important that you sit with your primary care physician and just address this issue. Let them look at how frequently you're going, how many times you're getting up at night. You may need a urine analysis. If he or she feels that you need a urologist to evaluate you for prostate issues, bladder outlet obstructive issues, then I'm sure they can make that referral. But it's a difficult question to answer in this setting, but that's how I would approach it.
Thank you.
I want to thank you for something that I've heard you all say that I have not heard other doctors in the prostate cancer group say.
What's that?
This clarification of what age is screening.
Sure.
It's not 50. It's not 55. I stand before you a 3-time cancer survivor of lymphoma, and prostate cancer. Don't applaud, because if it wasn't for my primary care doctor, my urologist would have failed me twice. And when you hear these numbers, you'll know why. I had a PSA of 2.7 with a previous cancer diagnosis. It's normal, but it could have been a high velocity. The next year, I went to a 5.7, and I was still told it's nothing to worry about. But thank goodness for my culturally sensitive doctor, my primary doctor said, to hell with that. And we're going to demand more. And I got a positive result of prostate cancer. But we caught it early at 44. But you all are saying something that I've not heard with other urological groups. And I know there's primary standards and urological standards of what age is screening. Know your numbers and that velocity. It's a green number, but is that velocity green? And then having that treatment. So thank you very much for saying that.